first slide today, representing acute pyelonephritis, which is acute inflammation of the renal parenchyma. It is characterized by acute inflammatory cellular infiltrate within the renal tubules and intervening renal parenchyma. The predominant inflammatory cells present in this type is the neutrophils. Also, congestion and edema are present. On high power examination, the predominant cell type here is the neutrophils, characterized by the lobated or multilobated nuclei. As a complication, papillary necrosis might occur, which is represented here by these triangular white lesions replacing the renal papillae. It is one of the complications of acute pyelonephritis, as well as it might be associated, especially in patients with the diabetes mellitus. Also, papillary necrosis may occur as a side effect of analgesic drugs. Once you have acute inflammation, you have to suspect or to put in your differential diagnosis a fungal infection. And to confirm or eliminate this differential diagnosis, you have to ask for BES stain, which is here demonstrating the fungal element represented by these elongated hyphae and rounded spores. If left untreated, acute pyelonephritis will progress to chronic pyelonephritis, which is characterized by chronic inflammatory cells, mainly lymphocytes and plasma cells within the interstitium and forming lymphoid aggregates. Some glomeruli will appear sclerosed and other will be spared. Also, there is a thickening of some blood vessels. The main cellular component here are lymphocytes and plasma cells, in contrast to acute pyelonephritis, which is characterized by neutrophilic infiltration. Another type of chronic inflammation, which is more localized and mass forming, is xanthogranulomatous pyelonephritis. Usually these lesions have well circumscribed bushing borders with yellow cut surface. Microscopic examination revealed the presence of abundant histiocytes, which display large abundant cytoplasm, which appear granular and vacuolated. One of the common lesions of the kidneys is acute tubular necrosis. Acute tubular necrosis, according to the etiology, is classified into ischemic and toxic type. They might be distinguished on histological examination by the extent of involvement of the proximal convoluted tubule. Usually, ischemic acute tubular necrosis is patchy and segmented or shows segmental involvement of the proximal convoluted tubule with some involvement of the distal, of the lobe of Henle, while in case of toxic acute tubular necrosis, the involvement and the inflammatory process will be diffuse along the proximal convoluted tubule as well as foci of the lobe of Henle. Microscopic examination will show vacuolization of the tubular epithelium with the sloughing into the lumen. Some tubules appears empty without tubular epithelial cells. Acute tubular necrosis, especially the ischemic type, usually occur due to hypoperfusion or ischemia. or severe hypotension like in cases of shock or heart failure. An example of toxic acute tubular necrosis is ethylene glycol poisoning, which is characterized by vacuolization of the tubular epithelium with dilatation of the tubule. Also, the ethylene glycol crystals will be seen within the tubular epithelium. So, constellation of these features, including prominent vacuolization of tubular epithelium, dilatation, and ethylene glycol crystals are characteristic of ethylene glycol poisoning. If the inflammatory infiltrate contains eosinophils, which are deeply eosinophilic cells with deeply eosinophilic cytoplasm and bilobed nuclei like this one, we have to build on our differential drug-induced interstitial nephritis, which occur as a side effect of many drugs like methicillin, thiazide diuretics, and H2 blockers like cimetidine. In case of gout disease, which is characterized by hyperuricemia, the high blood uric acid level will lead to formation of urate crystals and precipitation of uric acid within soft tissues, like in the synovial membrane, soft tissue around joints, tendons, as well as within the kidneys. Grossly, it appears like these yellowish foci scattered within the renal parenchyma. Usually, high uric acid level occur as or associated with gout disease, as well as a complication of chemotherapeutic agent, like in case of tumor lysis syndrome. As you know, usually malignant tumor has a large size, and on administration of chemotherapeutic agent, a large number of malignant cells will undergo lysis with release of uric acid into the circulation. This high burden of uric acid will be accumulated and precipitated within renal tubules. Under the microscope, it appears like these needle-shaped spaces, which represent the needle-shaped crystals embedded within a fibrotic stroma and surrounded by chronic inflammatory cells. If we talk about glomerular disease, this is a glomerulus, as you know. It is formed of glomerular capillary tuft confined to the Bowman space, which is surrounded by Bowman capsule. This site represents the hilum, where afferent arteriole enter into the glomerulus and efferent arteriole leaves the glomerulus. Sometimes during examination we face like these homogeneous eosinophilic material precipitated within the glomerular capillary lumina. This is an example of thrombotic thrombocytopenic purpura, which is a type of coagulopathy, might lead to acute renal failure. It occurs due to defect in metalloproteinase enzyme, which led to abnormal cleavage of von Willebrand factor and therefore abnormal aggregation of platelets with formation of fibrin thrombi within the renal glomerular lumina. This microscopic picture also might be shared or common between thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. Hemolytic uremic syndrome is a known complication of infection by Escherichia coli, especially the serotype 0157H7. Usually the affected persons are children, presented with a history of bloody diarrhea followed by acute renal failure. This kidney have a fine granular outer surface. It is an example of benign nephrosclerosis, which occur as a complication of diabetes and hypertension due to patchy ischemic atrophy of the renal parenchyma, will lead to formation of dimples and this fine granular appearance of the capsular surface. In case of malignant hypertension, multiple tiny foci of hemorrhage will appear within the renal parenchyma. This slide represents malignant nephrosclerosis. Microscopic examination will show either fibrinoid necrosis of the blood vessel wall with formation of a thrombus within the lumen, infiltration of the blood vessel wall by inflammatory cells with karyorectic nuclei. The other type of reaction in the form of hyperplastic arteriolitis, which is characterized by onion skin appearance with these concentric layers of thickened blood vessel wall. So it might present with fibrinoid necrosis or hyperplastic arteriosclerosis. Another example of injuries caused by diabetes mellitus to the glomeruli. It is nodular glomerulosclerosis, which is also known as Kiemenstein-Wilson nodules. This is the KW nodules. It is homogeneous pink hyaline material deposited within a part of the glomerular tuft. The rest of the glomerular tuft is spared, just one part is involved. It's occurred due to marked thickening of the basement membrane and deposition of glycosylation materials within the mesangial matrix.